What does it really mean to be a man in today's world? How does physical health as well as emotional health affect their quality of life? Bonding, male bonding, tonight as the doctors are on call.
Other than that, what are they?
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Welcome to On Call Television. We've done many shows specific to women's health, addressing specific conditions relating to breast cancer, uterine prolapse, ovarian hormone imbalance, and so on. But tonight is all about men. We have our particular problems as well, to include prostate disease, male skeletal issues, problems that relate to male work and recreation style, specific male aging concerns, heart diseases in men, and more. Tonight, we would also like to highlight the emotional and sociologic needs of men throughout their lives. Due to broadcast scheduling issues, tonight's show has been pre-recorded, and unfortunately, we cannot take your phone calls this evening. Save them for another night. Fortunately, we have been saving up questions from a variety of sites to include a clay shooting event and a sailing trip to the Apostle Islands on Lake Superior. Joining us for this Manly Men show are two special guests. First is Dr. Michael Gillett, a urologist who attended medical school at the University of Texas Health Science Center, San Antonio, and his residency in urology at the Mayo Graduate School of Medicine in Rochester, Minnesota. Following his training, he's moved to practice with urology specialists in Sioux Falls. Next is Dr. Matt Owens, a family physician who attended medical school at the University of South Dakota and his residency in family practice in Brookings on what was called the Rural Track Program through the University of South Dakota. He moved first to DeSmet to practice medicine for a few years there, and later moved to Redfield, which he points out is the pheasant capital of the world. There he practices at Redfield Clinic and the Community Memorial Hospital. Gentlemen, welcome.
Thank you.
Michael, you're a urologist, so let's talk a little bit about your training as a urologist. Where did that happen, and specifically, what did you learn?
I did my medical school in San Antonio, Texas, and did my residency at the Mayo Clinic in Rochester, like you mentioned. You know, we deal with all sorts of issues of the male genitourinary system, including prostate cancer, kidney cancer, bladder cancer, very common things that we see every day, enlargement of the prostate and issues that men can have with that, along with kidney stones and all sorts of other male issues. So
there we go. Not a lot of female issues.
We do some, but not a lot. Certainly we see more men than women, yes. Yeah.
Now, Matt, you're a hunter, fisherman. I mean, that's one of the reasons why I thought you would be the perfect guy for this show, because you're Mr. Manly Man, hunter, fisher, you know.
Manly Man. Now,
yes, there you are.
Been called a lot of things, but not quite sure I've heard that one before.
I wanted to point out, and I didn't put it out there quite as clear as I wanted to, that you did your residency in family physician in the rural track in Brookings.
Yeah, it was a unique program, not in existence anymore, but it was a program to specifically train you to be in communities less than 7,000, where you don't have a surgeon or you don't have internists and that sort of thing. And it was quite a good program. I think we had, what, 5 graduates? And we're all practicing in small towns.
Yeah, I mean, you know, and the wisdom of the governor, it went away.
Multifactorial.
There were
we're gonna leave it at that.
More than the governor's fault.
Yep.
So, but now you are in Redfield.
Absolutely.
And you, you want to talk about your training?
Sure. I did my undergraduate at University of South Dakota and did a master's in biology, emphasis in toxicology, went on to med school at Vermilion, and then completed my family practice residency program here in Brookings.
But you did some things before. I mean, both of you were non-trad students before you went to school. What did you do?
I had the pleasure of serving the United States Army starting.
I think they both did.
Quite a few years ago. I want to say back in the early 80s.
I'm
yeah.
sorry.
Yeah. Yeah. But Uncle Sam has released me, so.
Yeah,
You're no longer obliged to Uncle
Right.
Sam.
Yeah. I was a medic.
And you were a medic. Yeah. And then you you did special EMT or emergency stuff.
Yeah, doing EMS, and then I'm also involved in a USD School of Medicine is a very unique program in where we train students from all disciplines for disaster response within the state of South Dakota, and it's a variety of courses that are under a thing called the National Disaster Life Support Foundation.
Well, you have spearheaded this whole effort, haven't you? Yes, you have. You've had fun. And so what you've done is you've brought the Sanford School of Medicine at USD up to snuff, and probably we're the leading edge on training our kids to be ready for emergency.
To my knowledge, we're the only state in the nation that actually has a program that not only trains them, but brings them under state sovereign immunity laws so that they are available in case of flood, fire, whatever, to assist in the response. Yeah.
Yep, that's great. So thank you for your effort in that regard.
Yeah. Thank you.
So we've got a lot of questions, and I thought, you know, we have one coming up, but I would start with the issue of erectile dysfunction, because we'll do that and then we'll take that first question. Erectile dysfunction, ED, is a real common problem in my practice. Now, my practice is with a lot of elderly, old guys and gals.
Yep.
The gals never really bring this up. The guys bring it up, though, in all ages.
They always nod their heads when it's brought up, though.
Yeah, they do. So what's your take on that topic? I mean, what would be take-home issues that we should make sure people understand?
I think first and foremost, don't be afraid to tell your doctor about it. Most men, when they're on their own, don't say anything about it.
Unless the doctor brings it up.
Yep. A lot of times we have to initiate that. They don't bring it up. But it's a very common disease. We all have vascular disease. It starts in our 20s and it builds over our lifetimes, and that leads to a lot of erectile dysfunction, along with some other things, psychologic and non-psychologic.
Neurologic problems too.
Yep, absolutely. A lot of people are diabetic, a lot of people are overweight, and these things can contribute to erectile dysfunction.
Sleep apnea, is that a factor there? So
Absolutely.
there's actually, I think the clue I get when somebody says, say, doc, I'm just having some problems here, it's the time to do some screening tests. What would you say?
Absolutely. First question I asked, do you smoke?
That's the biggest.
Yeah, and that's one we can do something about right today. Next thing I look at is, are they diabetic? Is this that early small vessel disease that's going to get them in trouble down the line?
Okay, so we've got diabetes, we've got smokers. What other issues?
Well, in a primary care clinic, you check their blood pressure, and then, of course, look at their medication list. On high-dose beta blocker, that's usually an easy fix.
Well, and there are other drugs that can affect it too, but certainly, and I mean, alcohol. Alcohol is a big one.
It's a big one. Antihypertensives are definitely a big one that we see a lot.
Yeah,
cause and effect with.
Even hydrochlorothiazide. What about antidepressants?
That, and there's also some other uses for antidepressants for gentlemen that are a little fast on the draw. There's some side of...
You start the antidepressant and it slows them down a little bit.
Yeah,
which
works quite well.
There's some evidence that tramadol is reasonable for premature ejaculation is what we're talking about, and tramadol may be a fix for that as well.
Yeah, low dose SSRIs, I'm thinking sertraline off the top of my head seems to work pretty well.
Absolutely, yep. But certainly for erectile dysfunction, I mean, the oral medications are the mainstay. I think of treatment. Everybody sees the commercials with the tubs next to each other and,
Right.
and all of that. And
It works.
Yeah, they're very effective.
And
very
Bob Dole liked it too.
I thought the flip on the beach was the best thing. The question I would have, though, is testosterone levels. Do we draw testosterone levels in every guy who says he's having ED?
I don't tend to do that. If it's without any other symptoms. You know, if they're telling you that their libido is way down, their interest for sexual activity is down, that's a big key. Fatigue, irritability, depression, just, you know, losing muscle mass, these kind of things, then I think about doing it. But if it's strictly ED, I usually don't do it right off the bat.
Okay. So let's take the next question. Let's hear it from, I think we're at a hunting clay shoot experience here.
Hi, I'm Rich Woodman from Brookings, South Dakota. I have a question for Dr. Holm and the panel. Being that it's close to hunting season, what do you recommend for exercises before going out in the field and any stretches while we're in the field?
Great question, Matt.
Well, the main thing is to start before the season. And what I recommend is 20-30 minute brisk walk every day. You know, the old stretches.
For a month or 2 months.
Yeah, especially as you get older. The old stretches we did back in football, you know, where you sit down, reach down, not standing, but sitting down on your hind end and reaching down and stretching out your Achilles tendon, your gastrocs, and also stretching out your quads will go a long way. The biggest thing I see in the ER early pheasant season, or in the clinic though, is people just that have boots that don't fit right. And so they come in with all kinds of foot and forefoot and knee pain that could have clearly been prevented just by breaking in their boots.
Yeah, break in your boots and walk for, do a mile walk every day for a month. Any other comments?
I agree with that completely.
That's good. I like that. Well, I'm going to ask for the next question.
So as I get older, I have more aches and pains, especially maybe arthritis, and it's in the neck. And I'm wondering what's some of the better things that I should really be doing? Is there some medication should be taking, or to relieve the pain, or just exercise? And
Okay, that's great. And of course, you can see the sailboats and Lake Superior beyond. We're out on an island. And the question has to do with generalized arthritis, but neck arthritis. Matt, I'm going to lead you to you.
Yeah, it's a real issue, and I'm not a drug pusher on this at all. We've had really good luck. We have a really good physical therapy department there at CMH, and you know, even just a quick trip down there for one set of how to do some cervical range of motion, trapezius range of motion, that sort of thing. And folks can do that on their own. It's low cost, it's effective, and I don't have to worry about any drug side effects.
I think you don't gain a lot with the drugs here either. I think it's the range of motion that matters. I always say there's the 3 exercises. There's the yes exercise, which is yes, and there's the no exercise, no, and then there's the I don't know exercise, which is like or. So it's left and right, up and down, and ear to shoulder. And if you can do that sort of through the day, your neck gets limber over time.
And just look how the patient's sitting. If they're sitting all curled over, that can be 9/10 of the problem right there.
Posture's a big thing. I think you mentioned, you know, over time things get better. You know, a lot of times people do them one day, things don't get better. And you have to continue to do it day after day, and you have to give it time to work.
Yeah. That's it. Well, let's go back to the urologic world here and bring up the issue of the prostate. Because first condition that is pretty darn common is something that comes with every man who gets older, called benign prostatic hypertrophy, or BPH. What is that?
It is simply overgrowth, if you will, of the prostate. And probably anybody that lives to 80 years old has probably an 80 or 90% chance of having BPH and symptoms from it. The prostate, I always say, is kind of like the earlobes. It never stops growing. Grows about 2% per year.
Oh, it's like earlobe. I've never heard that. That's good.
That's a new one for me, too.
It just never stops growing, and you know, that's why in your 40s maybe you start to notice something, and then just year after year after year symptoms can creep up on you. Symptoms like I get up more at night to pee. I have a more difficult time starting my urinary stream. I don't feel like I'm emptying as well as I used to. I go more frequently. When I gotta go, I gotta go. and I'm sprinting to the bathroom, and things like that can all be signs, symptoms of BPH.
I used to say if you get up at night, that's the first sign, one time. Well, sometimes I'm thinking, well, if you get up one time, then you're hydrating correctly. So maybe 2 times is the issue, and when people start saying it's bothering me, then I start responding.
Yep.
So what would you do as a diagnostic workup for these people with symptoms like that?
In most cases, if it's simply one of those symptoms like we had mentioned, treat empirically. You don't really have to do a whole lot of workup for that.
Empirically meaning?
Meaning just start with some conservative measures. I see so many men and people that don't pee often enough. A lot of truck drivers, a lot of farmers, a lot of teachers, accountants in March, they wait 4 or 5 hours in between voiding. Typically you should void 6 to 8 times, go to the bathroom 6 to 8 times during the day. If you're going 2 or 3, it's going to cause troubles in some of those symptoms. So certainly time voiding is a big one that I push on people.
Matt, any?
Yeah, I guess on the primary care side, one of the things I do, because we're always looking for other things, colorectal cancer, that sort of thing, I don't necessarily jump to the PSA.
No.
But I usually try to get a digital rectal exam, just to make sure that I got just an enlarged prostate, nothing else going on there.
Yep.
And
People don't like it, but it's pretty darn diagnostic.
It's a necessary evil.
And in responding to this issue, I have to say this, that I make no apologies. If I'm at a meeting and I have to go, I just get up and go. I don't hold it anymore. I just, no apologies, sorry, gotta go. And I just do it. And of course, since I'm a big coffee drinker, I have to go a fair amount in the morning. In particular, I don't apologize. I just don't hold it.
Your body's telling you it's time to go.
I try not to hold it. But if I'm getting into trouble, now a lot of people will talk about medications. There's 3 drugs I want to ask about. The first one is the alpha blockers. There's a bunch of them. Flomax is the classic, now generically available. A bunch of them that are that are cheaper maybe. And their alpha blockers are quick acting, and they relax the sphincter. So that's neat. The problem is they also relax your blood vessels such that when you stand up quickly in the middle of the night, you get lightheaded and might hit the floor. Any comment?
They are. That's I warn everybody that I put on those medications. If you have to be careful the first time or 2 you take that medication. If you stand up quickly, you may get lightheaded, so be prepared for that. If it doesn't happen the first time or 2 they take it, it doesn't typically happen. So that's you kind of give it a little trial, but they're very effective medications.
Yes,
and their costs really have gone down.
$4 a month.
Yeah, down.
Very cheap and well tolerated, really. I mean, it's a small percentage of men who have troubles with them.
And I don't think there's one that's better than the other. So I've always gone the generic, and the Flomax is now turned generic, and there's new ones. But basically, alpha blockers work, and they're fast.
Yep.
They give you any sexual dysfunction?
They can.
A little.
They can cause a little bit of trouble with what we call retrograde ejaculation. Where when you have an orgasm and ejaculate, it can go backward into your bladder instead of coming out. The men that we treat for BPH are older. Hardly any of them want to have kids anymore, and that's usually, it's not harmful. It's usually not a big issue.
So an orgasm is an orgasm. If it goes forward or backwards, who cares?
Right. Yeah.
So the second group is the finasteride, and there are other drugs that are like that, and that's sort of like the over-the-counter
saw palmetto.
Saw palmetto.
Yep.
And basically that works to prevent the prostate from receiving the message from testosterone to grow, and it causes it to shrink.
Right.
But it really hits the sex function.
It can, yeah. It shrinks the prostate on average about 20% for either one of those medications, but it takes time too, and that's one thing you have to warn people of, at least 3 to 6 months. Before you may see significant benefit from those medications. But you're right, sexual side effects can be an issue with those.
Right.
In my practice, a lot of my gentlemen are 80 and over, no longer looking at that as an issue.
Some of them. I asked them.
They're pretty upfront telling me about it. They're saying, Doc,
don't mess with my sex.
Yep.
Good for them.
So that's the third question. There's the third drug. Now, right now, one of the erectile functioning drugs, Cialis, right, is saying, okay, instead of 10 milligrams or 20 milligrams, an hour, 3 hours before you jump in the tub on the beach or whatever they're advertising.
Where do they get the tub?
The
That's what I want
tub.
to know.
Where?
On the beach.
I don't understand.
On the beach. I've never got that. But
I've never experienced it.
But I mean, But so you get the Cialis and you take it 5 milligrams every day.
Right.
Sexual function improves.
Yep.
Does it work for prostate?
We know that symptoms improve. We may not know exactly why symptoms improve, but they do seem to improve with it. Meaning, patients, when they pee with a better stream, they feel they empty better, and some of those symptoms do go away. Yeah.
So, I mean, one might consider doing that. It's spendy.
It is expensive. It is akin to doing about 8 Cialis tablets a month. But yeah, they're $15 a piece or something. They can be expensive. And the FDA has only approved it in men who have hypertension, high blood pressure, and expect to be sexually active at least twice a week.
And as far as the long-acting, I don't like them. And here's why. If the short-acting, like the Viagra or the once-a-day Cialis, let's say if you come in and you're having chest pain, I'm suspecting angina. If it's a Viagra product or a Cialis product that's the short-acting, it opens up some possibilities for me to use our go-to drug, which is nitrates. Where if they're on a long-acting Cialis, I got to stop right there.
No nitroglycerin for these people at all.
Yeah. I'm careful about the patient population that I give it to. Yeah.
Yeah, and so I'm kind of, here we've got a person who's really having problems. They're sort of wanting to have sex, but they're willing to give it up because, well, I mean, I'm 80 and, and I don't get it much. And, well, okay, I'll take the medications, okay? I'll take the drugs. And so you start them on an alpha blocker, you add the Proscar, and it works pretty good. Combine the two. Yep. They do pretty well. They do lose their sexual function. And then they get lightheaded when they stand up. They have blood pressure problems. They're on all these pills and so on and so forth. Why not just do the old TURP, the Roto-Rooter, the transurethral prostatectomy, or the newer versions, which you use
various forms of lasers and different heat-based technologies.
Why not? I mean, it's and long run, if they live longer than 3 years, it's going to be cheaper.
Very effective treatments. A lot of men are just scared of having surgery, especially down there.
But it doesn't mess with their sex function.
No, there's a 1% chance with the old-fashioned way of doing it.
Yep.
With the lasers and the newer techniques, really no risk of erectile problems.
So what do you think?
I think it's a great
option.
Yeah.
So if I said to you, look, hey, I'm still sexually active, I don't want to take the pills, how about a TURP?
I think,
Will the insurance cover it?
Yeah.
Okay.
Yeah, I've never had an issue with that.
All right. Well, we've got another question from some character. I don't know where this guy came from. I don't know, let's see what he has to say.
We've seen in recent years with the marked reduction in coronary artery disease deaths and the role that statin drugs play in that. Some people believe that that's a great help, and others believe that it's not. In fact, believe that the complications of those medicines are so severe that they should not be used. I was hoping you could give me your advice.
Well, that was Dr. Jim Reynolds, kind of a world famous, certainly South Dakota famous cardiac surgeon who was sailing with us that week. So what's your take on that, Matt?
After diet, exercise, lifestyle modification, if they fail, they're definitely the go-to drug. Now, especially now that more generics now they need some drug monitoring. Need to monitor, as far as liver function, that sort of thing, monitor for some of the side effects. But they're literally changing life expectancies, both for stroke and heart attack. I know the stroke data is not as good as the primary prevention, plus minus secondary prevention. From what I've read, it looks very, very compelling.
I'm going to jump in with my opinion because it's not in agreement with you. I think that the Archives of Internal Medicine editor cardiologist was giving a lecture at the Annals of Internal Medicine, or at the ACP meeting, the Internal Medicine meeting, and said in primary prevention, this $55 billion industry using a lipid-lowering drug hasn't been shown to decrease MIs or heart attack risk. It lowers cholesterol, and we do know that cholesterol is a risk factor, but we don't know that lowering it prevents heart attacks in primary prevention. Now, that's not talking to people who've had heart attacks. It's talking about people who've had. Now, give me your disagreement.
Yeah, well, I'm going to flip that back on the backside is that as I brought up earlier, the primary prevention data is pretty unclear.
That's what you did say.
I did
you
say
did
that. I had my caveat in there, and no,
yes, you did.
I do not have any stock in Pfizer.
Okay.
Okay, so we're clear. But no, as far as secondary prevention, I think it's clear.
Secondary meaning the person has had a heart attack.
Or had
Clear
yep,
cut. It is clear, and I agree.
And because I see so many people with coronary artery disease, once again, after diet, lifestyle, all those modifications, if we're still got an LDL that's floating up there in the 150s, 160s,
you'll use it.
Yeah, absolutely.
I think in secondary prevention, but in primary prevention, certainly with the side effects of those drugs, memory loss, profound weakness, joint problems, I think we have to realize that a good percentage of our people do have those things. So every drug needs to be used carefully. I mean, particularly polypharmacy is a bad thing.
Yeah, we see so many patients that are on this, 20 medications. It's very difficult to deal with those. And I like the comment of after lifestyle changes, diet and exercise.
Beautifully done.
That's what that comes first.
Very good.
Nothing will beat that.
All right. Now let's talk about controversy again. There has recently been.
You gonna disagree with me now?
Yeah. No, we're gonna. Well. So the question about doing PSAs, I mean, there's been a lot of question about whether it's been helpful to people that, and in fact, that has brought people to getting radical prostatectomy where they've lost their sexual function. There's been the risk of the surgery. Some have died from the surgery. Mm-hmm. And what's more, then they have a dribble, and then they've lost control, and they wouldn't, the PSA, they wouldn't have died early from that prostate cancer anyway. And on top of that, the PSA has not only sometimes goes up when there's no cancer, and there is cancer sometimes, and the PSA doesn't go up.
Sure.
So it's a crappy test, and it's bringing inappropriate surgery is the argument, and so the U.S. Preventive Services Task Force says, no more. Do no more PSAs.
Right.
Now that's
as a screen.
As a screen.
Let's make sure the audience knows as a
That's
screen.
right. You can use it when you've got indication that there could be prostate cancer, and it can give you a clue, not a proof, but a clue that there's something that's what you're dealing with.
Or certainly in men who have been treated for prostate cancer.
It's a wonderful
very good test.
monitor because it helps you know.
Yep. Recurrence.
That's right.
I mean, you bring up a lot of the points that have been made about prostate cancer, about PSA screening. I don't want to take a lot of time, but the U.S., the government task force that just in May this year came out and said, don't do PSA screening in any men, any age. It consists of a group of non-physicians as well as primary care physicians. I know the chair of the task force right now is a pediatrician. I'm guessing she has never counseled a patient regarding prostate cancer. She's never done a screening. She's never treated a patient. They did not ask for any input from urology, from oncology, from patients, from any experts in the field. And there's a reason why in the U.S. Congress right now there is legislation pending that changes the way they do business because of these issues. So I have concerns about where the information is coming from. They took two big trials that came out in 2009 that were done, one in the U.S., one in Europe. I don't know if you're familiar with these, and they were both in the New England Journal. Mm-hmm. One of them was the one in the United States, 75,000 patients, showed no difference in mortality. The same number of patients died whether you were screened or not. The trouble with that data is that more than half of the patients in the control group, the ones who were not supposed to be screened, got screened. It's a faulty data set. Right. You can't even use it. The European study, which had 160,000 men, now shows, with updated data that came out in March, a 30% reduction in prostate cancer death. There are at least 12 countries in the world that have come out with the same thing, 30 to 40% reduction in prostate cancer death. So there's a lot of talk about, how do you offset these? I think the one in the U.S. you just can't use. It's not a good data set. But there's also other issues here that they didn't really address. There were no African Americans in these studies. African Americans are 50% more likely to get prostate cancer and twice as likely to die from it. We can't get any information regarding them. Before PSA was around, 20% of men who were diagnosed with prostate cancer had metastatic disease, spread of prostate cancer outside the prostate where it can't be cured. After PSA screening has been around, it's 3%. Huge reduction in metastatic disease, which is very costly. And if you've ever seen somebody that had that, it's painful. You know, it gets into the bones and it hurts. It blocks their ability to pee, the outflow of their kidneys, and they need all sorts of procedures. There's a huge burden there that we're not even talking about with the screening. So I think there's a lot more to it than what you see. And you're right, there are many men who get treated that don't need it. And I think it is up to the expert, the urologist, the oncologist, the people that do it every day, to talk to the patients and counsel the patients. And you know, I talked to 2 patients today and said, you don't need PSA screening anymore. You're of an age in your 70s, you've had heart attacks or something along those lines, you don't need it anymore. So you know, we have to be upfront with patients too, and we haven't always been that way.
Okay. I'm in agreement with that totally, because it's just like any other screening test. I remember back in the day, going back to your lipid talk, down at USD we did a bunch of lipid screening. Well, if the average age of the people you're screening is 85 to 90, that's just invalid.
Yeah, we have to be smart about the way we're using it.
Well, and if you look at the people who you can catch prostate cancer early that makes a difference, it's the younger person.
Exactly. And plenty of studies say if you're younger, the odds of you being cured and the risk is better, and the risk of death is lower. In these studies that were done, you know, nobody was younger than 55 in those studies. So we don't really have anything that says, well, what if you're 50? Like the gentleman I saw in my clinic today, who's 50, he didn't get screened as the recommendations are. He had a PSA of 320 when he came to my clinic. Yeah. If he would have been caught with screening as it's recommended, he probably could have been cured. There's a lot of men like that.
And correct me if I'm wrong on this too, but let's go back to that screening thing. Their initial data, that when they did that statistical analysis about 8-10 years ago, when they set the norms, maybe it's more like 15.
Yeah,
I'm aging myself.
Yeah, it was the late 90s. Yeah.
Up what, 4.5, 4 upwards?
4 was
normal?
the number that they used in the States.
One thing for our younger males in the audience is if you're 40 and you have a PSA of 3.9, that's not reassuring to me.
Oh, no way.
Yeah, no way.
That's way
it's
too
an
high.
age. Yeah.
It goes up with age. But I think there is something to learn from all of this. If a thing is so hugely effective, it's obvious. There's no question. We all agree. Yeah. And when it doesn't work at all, flat, zero, it's obvious. It's those borderline things.
Right.
And that's where we're at here.
It's not clear cut.
It's not a great test.
It's not clear
I
cut.
wish it were a better test.
Yeah.
And you can sure cause a lot of trouble.
Yeah. I think you know, some of that, in my opinion, seeing it every day and doing prostate cancer surgeries all the time, the fear that is being struck by some of the comments that the task force made, I think, is overblown. You know, they talk about deaths from biopsies. And in these 2 big studies, 50,000 men were biopsied, 0 deaths.
Yeah, 50,000.
You know, and it's just way overblown.
I've heard it's not the most comfortable thing. Haven't heard anything about it.
That's way overblown.
Yeah.
I would say that I am on that border, and I mean I'm constantly changing my mind. I like to think that I'm the guy who's always right. I know the answer, and here it is.
Yeah.
I'm taken aback by the data.
What do you think about, you know, if you are a 52-year-old gentleman whose father passed away to prostate cancer at 56 and whose brother had it at 49, and all of a sudden we say you can't have a PSA? It's not going to affect your life. Yeah. Are you okay with that?
No. And it really comes down to it. You have to understand, screening tests are one thing. And if you do a screening test and it brings on all sorts of trouble too, that's different than doing a PSA when indicated. And it takes it out of our direction as a clinician to be able to see the individual, think about that special situation, order the test that we need to order. Yeah. Unfortunately, there's not consistency across the country that people are doing it in a rational individual
That's
way.
correct. I mean, we need a lot of teaching and a lot of education for a lot of people because it's used inappropriately in a lot of cases.
Yeah, like in my practice, since this came out, it's actually been kind of a good thing because I can talk to my men, say in their 80s, that have multi-disease and say,
don't go there.
Don't go there.
Yeah.
And if you have a lot of symptoms, we can talk, but
and
up
that's
twice
a very
a night,
appropriate way to do it. Yeah.
You're 80 years old, you're up twice a night, you've had bypass, you're good.
Yeah, I agree.
All right.
I just, we're taking any of the decision making out of the hand of the person that's affected the most, the patient.
Yeah.
And I think they have a right to at least make an informed decision.
I had a man who said, I want a PSA, and I said, today, okay, but here's the data.
Okay. Here's exactly.
I'll still do it.
Yep.
All right, we have another question.
I'm wondering, a lot of men get phlebitis or blood clots in their legs, and what are the symptoms that you would have when you have that, and what should you do? Should you see the doctor right away, or should you get your leg up, take aspirin? That's my question. Okay,
deep venous thrombosis, when do we know we've got it, and maybe we've got an early case? Matt?
There's two issues there. One's phlebitis, superficial inflammation of the phlebes, the veins.
The veins.
Yeah, another one's DVT, which can kill you. That's a deep vein clot that 50%, I think the old data that went to the knee would go to the lung and on to stroke or pulmonary emboli. So if male or female, you have swelling, edema, especially if it's on one side.
Swelling is edema.
Yeah, and with or without pain, that's a trip to your doctor or to the ER. That is, we argued about PSA before. This one's a no argue one. If you've got obvious unilateral swelling, you need an ultrasound and you need to make sure that you do not have a clot.
Well, but I wish I could believe that the ultrasound always is correct.
I believe too,
but here's the deal. I also, if it's below the knee and it looks superficial and it's not hot, I'll treat without warfarin, without heparin. I will have them elevate, I'll put heat, I'll put ACE wraps, I'll monitor. But I'm nervous because I had a man, I've had patients die from clots from their leg, no question. Mm-hmm. But I think that's a good answer. We have, I think we're going to take another question, okay.
What are the biggest health issues for 20-somethings to face? Should I get the HPV vaccine?
Okay, so let's do the HPV vaccine. Handsome kid, wouldn't you say? Handsome guy. Happens to be our third child, Preston Holm. What about HPV vaccination, and what about doing it in men? Let's start with you, Mike.
Yeah, I mean, I think it's been shown to be a reasonable.
What is it?
Alternative. It's a virus. The HPV is a virus. We see it in my practice. It's a sexually transmitted disease when I see it, and we have to treat genital warts, and that's the manifestation is genital warts.
And to prevent them, this vaccine, and it works.
Yep. In our practice, initially the CDC cleared it for I think young women under the age of 14 without having any previous sexual activity, and then I think somebody woke up in Atlanta and said, well, if we're treating the girls, we probably better be treating the boys. Yeah. Hello.
Takes two to tango.
Yep.
Two to tango.
And that's another one of those things. It's kind of a loaded issue, when you start talking about morals and reality and that sort of thing. But if we thought we could do something to prevent the risk of, say, cervical cancer, any of these other virally induced cancers, and we're also seeing them in the head and neck now.
Right. Mouth cancer, head and neck cancer, that's it.
And you say we can prevent it, to me that's a way to prevent it. There's other ways to prevent it too, but the vaccine works.
Vaccine works. So I think we have now we have an interesting presentation about manly men. We've spent most of the show talking about physical health issues, but believe it or not, men have an emotional and psychological side that needs to be addressed as well. This past summer, 18 men with 3 sailboats spent several days sailing Lake Superior around the Apostle Islands of Wisconsin. The group ranged from 21 years of age to early 70s. Everyone had a reason to be there and added value to the group experience of men. Sailing on Lake Superior, 18 guys. What is it? Why do men like to get together?
Yes, you know, we just hang out, and sometimes you have some interesting conversations. Even get into politics, where there is a spectrum in this group from very liberal Democrats to very conservative Republicans, and it's okay.
It's okay.
It's okay. Yeah.
That is.
I was in the middle of something when this was happening, and I had kind of thought about maybe not coming. And my wife just said, "You have to go." She's seen over the years different men that she has known, her father and other people, that isolate themselves. Men isolate themselves. And so this is a huge deal to go out with a bunch of guys. There's a half a dozen guys on here I barely know, but we're all having a good time, and you always think, well, maybe I'll make a new friend or a lifelong friend from a involvement in something like this. So I try to go on all of these that I can, and my wife encourages me.
Men aren't as social as women, and you know, if you ever go to a cocktail party and see what happens when you walk in, the women all get together, they're talking, the guys are standing there with a drink with their arms folded by themselves, usually.
This gets into the role of mental health, that this is why we're so healthy, as we've done all these male trips. But no, I mean, I think that it's important to do multiple things in your life, and including male activities that usually center around sports or hunting or those sort of activities. And the old saying about absence makes the heart go fonder, I think applies when we go home. I think it's a renewal for Debbie and I to have had a time of separation.
Yourself and a friend going out on a hike, or whether it's 18 guys, you know, chartering 3 sailboats and sailing in the Apostle Islands, it's camaraderie, and you meet new people, and you learn things about other people that, you know, ultimately teaches you more about yourself.
It's just good to get together. I mean, I think we're social animals, and you know, couples get together, men get together, women get together. Everybody, you need to mix it up with everybody. Yeah, it's good for you.
Well, of course, you got to have the camaraderie, but you got a group of your peers. You learn from them. You hang around with them. You hope that you can teach some of them something. I mean, the age factor alone, 21 to 70. Obviously, I'm learning a bunch, but hopefully, I'm teaching a little bit, bunch as I go.
A bunch of guys that get along great, all different walks of life. There's no judging. There's no conflict. Just a fun group of people to be with.
A great time to go do things with, you know, people that are a little more inclined maybe to like doing similar types of things. So, you know, for me, my wife will kill me for this, but she doesn't like to camp necessarily. She'll go, but she's not interested in getting quite as dirty as I am. So, a group of guys, that doesn't seem to bother them quite so much.
That's just an extension of our desire to be healthier, because there's also psychological health that we have to worry about. And I think that to get out, to be alone, not to have your spouse to whom you might be the person that you identify most with, that you have to really be yourself, and then work and deal with other people in a fashion that really boosts your ego, maybe makes you be a better team player, and maybe pulls you out as a leader a little bit. And I think it's a learning experience. Plus, it's a lot of fun.
You know, there's some stuff you can't do or say in front of women, and they get all uncomfortable or something. And it's just a good time to relax and have a good time.
I think it's great. We all get along really well. I think there's a lot that the older folks can teach the younger guys, and I think there's a couple things the younger guys could probably teach the younger folks. So I'm glad there's this much diversity. It's kind of the camaraderie. You know, we're sort of part of a brotherhood, or I don't know, kind of like there's something like a bond that forms pretty quick, and it takes a little bit less effort when a bunch of guys hang out than when there's a mixed, you know, group of men and women. It's just we get a quicker bond.
Just getting out of the house and away from the wives.
There's a time to do that.
Yeah, this is the time.
Oh, that was a great trip. I'm sorry you guys weren't along.
Rick, that was way too warm.
I was starting to get uncomfortable.
Oh,
That was too. Yeah. It's that manly man thing.
That manly man thing, you know. Well, I tell you, the experience, and this is the 3rd year that we've done this sailing trip, and you're invited if you'd like to go, by the way, is basically just an adventure, you know, and learning how to do something different. And that's the excitement, yet this is an opportunity really to see how people interact differently. And I think men like to be away from their wives for a little bit to see how I act differently, because we don't do enough of that. I think in this nuclear world, sometimes we isolate.
Yeah, I think it's very healthy. He said absence of the heart growth responder. I mean, it's a great thing, and we've done that over the years too, my wife and I, and you know, when you're together then, I mean, it's, I think, a better relationship for it.
And you kind of learn other coping skills from other guys, because we're all kind of going through this thing together, you know.
Yeah. So let's talk about emotional health in men. And part of the thing that this brings up is the issue of isolation. I think in particular men who lose their hearing, they become more and more isolated because you can't talk to them very well. They can't hear what's going on. And men are quieter anyway. And so they get quite isolated in the end.
Yeah, in the clinic, say a 70 and older male, his wife's saying they're not going out anymore, they're not even going out and checking on fields. Red flag, you need to start working it up, see if you've got either an endocrine problem. A lot of times it's psychological or behavioral, not even necessarily depression. It can be the hearing aid's not working, or maybe they misunderstand what their role is. And that's an important thing. A man that's kind of going into the cave mode, that's a big flag, big red flag.
You know, the highest risk for suicide is, are you ready? Male, older man who recently lost his wife.
Yep.
And they do it in a violent way.
They're very effective at it.
Yeah, and so in that group, we've been clued in as physicians to, when we have a male that's suddenly alone, wrap a little bit of loving around him and get him interested in something and get him down to the coffee shop and hang with the guys. I do my reading at Cook's Kitchen on Brookings Main Street, and you know there's a couple, there's like 3 women or 4 women that kind of meet there, but the rest is men, and it's a table of men over here, a table of men over here, table of men over there, lots of joking, lots of interacting, and I think it's pure 100% inexpensive psychotherapy. You know.
Kind of a testosterone Starbucks sort of thing?
Yeah.
Okay.
Yeah, I mean, how many of us, you know, our dad retired whatever age he was, and he goes every morning for coffee with the guys.
Yeah, coffee with the guys.
Yep.
There is the thing about the group dynamic. What's that?
Not sure how that works. I've got a kind of a group that comes up, and we all chase pheasants and ducks and run our bird dogs, and yeah, there's something to that. I haven't looked into it from a science standpoint, but therapeutic to yell at their dog and then they yell at my dog. And, you know, it's just all works.
Yep, it's all in good fun.
Part of what they say we miss is the ritual of maturing for kids, that we don't, as adult males, teach young people the value of male mentoring, support, give them love, and teach them not to be violent, teach them to be protective. And our gangs, are men looking for a leader, and the leader, unfortunately, is saying, no, violence is where it's at. We need to have, and they say part of our societal problem is that we don't have mentors teaching kindness and openness and responsible protecting.
We got gangs in South Dakota, we just call them 4-H. They're appropriate.
Oh, but appropriate gangs.
They're active, they're working their projects. That's exactly fills that dynamic. Now, it's not just for men, there's obviously women in there too, but yeah, very active thing, very much a part of that process. And a lot of them come right here to SDSU to further their ag degrees.
Great. So we've got a little bit more here right after this. let's face it, men are built different than women, and one aspect has to do with communication. Women reach out and get emotional support better than men. Men like to fix things, but we don't always like to talk about it. And with modern nuclear families, all the activities and television dependence, men can sometimes become isolated as old male friendships drift away while wives are speaking on a different wavelength. What is missing with this picture? Anthropologists tell us that throughout the ages, from every corner of the earth, men have come together with other men to hunt in order to provide for food, to fight in order to protect their village from raiders, and perhaps more ancient than all, to have ritualistic rites of passage for young males in order to teach them how to protect families and villages from threats of all kinds, and how to act in society. Robert Bly, a Minnesota poet, tells us that men have always needed other men in their lives and still do, perhaps more than ever. He advises us that a man's work is to not deny his inner suppressed wild man, and at the same time to learn from other men principles such as the work ethic, honesty, loyalty, and especially respect. He needs to learn that virtue and justice is the goal, never violence, betrayal, or abandonment. Well, many of us have had this type of experience with our dads, or with playing sports, sometimes with gangs, or with dorm life in college. If we're lucky, some guys continue men's work as adults with coffee groups, poker nights, golf outings, football parties, hunting trips, and in my case, a weekly gathering to sail and or to cook. Last night we met for a thrilling, windy yet warm October sail on 3 boats with a venison feast that followed. It was a night with diverse opinions about presidential politics and about many things. But we have learned this is a place we can speak openly and honestly, with lots of laughter. Of course, much talk is always about women, how we will never understand them, and what we appreciate about them. For me, having male friends has greatly enhanced the quality and depth of spousal and family relationships. If you're a man without a group of male friends, you need to fix it. Well, that brings us to the issue of issues of depression in men. Let's talk a little bit more about that. A woman presents depressed, very sad and obvious. How does a man present depressed?
From what I see, they retract. They go into their cave. They become quiet, no energy to do things, don't want to accomplish tasks that they normally would have accomplished, non-communicative.
Or a real change in substance abuse is usually a real key sign that a male's having some problems coping.
They drink more.
Drink more. Yeah.
And of course, Mr. Jones, I think you might be depressed. And what do they say?
No, no, it can't be me. And then follow-up questions are things like, how's your sleep? What's your activity? For a male, you're going to get more out of those 2 questions than tell me about your mood. Tell me more about your activity.
Yeah, talk to them about their activity.
Yeah.
And I don't think you need, I don't talk about, well, there's this antidepressant pill. I give them a pill that helps them with their anger. I mean, it helps you cope with anger. I mean, we can talk about depression or whatever, and I don't know what depression really is, particularly with the men, but it helps with anger.
What are you using for anger?
Or an antidepressant.
Oh, okay. Okay.
Yeah, I wondered that was over my head.
Yeah, no, I think when people present angry all the time, that's the first big sign on a guy for that there is significant depression.
Yeah. And I know my experience with that, you know, I don't deal with it directly necessarily, but it's always the wife is sitting behind him going like this.
Yeah.
You know,
there's the clue.
Yeah.
The wife says,
He's been a little irritable,
and he wouldn't have
says
been,
no.
Yeah, wouldn't have been there hadn't it been for her.
Yeah.
Yeah.
Well, this brings to a close our show on men's health. I sincerely thank our studio guest, Dr. Michael Gillett, and urologist practicing with urology specialists in Sioux Falls, and Dr. Matt Owens, a family physician who practices at the Redfield Clinic and the Community Memorial Hospital in Redfield, for helping answer all the wonderful questions about men. We'll leave you with this thought from Mark Twain. What would men be without women? Scarce, sir, mighty scarce. Until next time, stay healthy out there, people.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed cap.